And it's been an honor to be invited by the PACE GWICC, Dr. Ma, and the organizing committee. Really appreciate being here, and it's a delightful conference. There is a lot of shift in the way that we are going to talk today in the next few minutes about the atrial fibrillation management. It has changed over a period of time what we understand in atrial fibrillation side, and it will continue to understand. So these are my disclosures. Let's move on to the objectives of today's talk. We're going to discuss the shift in the atrial fibrillation management from rate control to rhythm control. I'll go back a little bit basics about how we really dealt all along and how we have changed. Describe early rhythm management. Identify the critical role of atrial fibrillation, especially with respect to heart failure, and examine what is new in AFib management. So why paradigm shift? So, the interesting thing about that concept of what we understand for atrial fibrillation management all along and now, the starting point is the guidelines. If you look at the guidelines from 2023, it is summarizing all the evidences what we have learned over a period of time with respect to how we manage the atrial fibrillation. This is probably one of the reasons I think there is a big change with the available literature now. So what we previously understood in atrial fibrillation management is rate management was good enough to manage atrial fibrillation compared to the rhythm. This is what we all along understood from the RACE affirmed trials for years. And the interesting aspect is many cardiologists were not referring patients for rhythm management for a long time. They always believed, particularly in the heart failure population, if you go to Heart Failure Society, they didn't even believe that atrial fibrillation was a very important role. It was thought that it is an epiphenomenon of heart failure. So rhythm management, we had a problem, nevertheless, to say that antiarrhythmic drugs are not the best choice what we have. There was lack of good tools for ablation, and then lack of studies proving that atrial fibrillation management with ablation was a good modality, and unknown completely in the heart failure population. So let's scale back and look at the definitions of atrial fibrillation. This is an old, I will call it this as an old definition, as paroxysmal persistent, long-standing persistent atrial fibrillation. I'll tell you as you understand over a period of time what it really means. So let's look at the atrial fibrillation as a risk factors. There are three categories among this particular slide, as you can see. So the first category is the atrial fibrillation. This particular part is the risk factors. These are the risk factors you traditionally see with all the cardiovascular diseases what we see. So atrial fibrillation is not just what we are seeing as a rhythm issue. It is a phenomenon that is going on in the heart and the rest of the body. So it is creating a perfect milieu to develop a substrate within the atrium which leads to atrial fibrillation, which results in all the cardiovascular outcomes. So let's keep this slide in our background as we go further. So this led to a very important trial, possibly one of the early landmark trials with respect to looking at rhythm management. So the early intervention of atrial fibrillation was done with an intention to show that rhythm management was possibly beneficial over especially if you intervene early. In this particular one, the primary outcome was the composite of death and from cardiovascular causes, stroke or hospitalization with worsening heart failure or acute coronary syndrome. In this, the hazard ratio was 0.79, meaning it really made a big difference with respect to the outcomes in early intervention. In this particular trial, the patients enrolled need to have atrial fibrillation less than a year, but the median was 36 days. But if you have a cardiovascular CHA2 risk score greater than or equal to 4, the subsequent trial showed the hazard ratio even was further better, indicating that the early intervention is a very crucial step in the atrial fibrillation. So what happens in the chronic atrial fibrillation is chronic atrial fibrillation means rhythm control is not possible at some point. This is one of the things we need to understand. I will actually elucidate with this with a case of one of my patients who presented in 2010 with he was 73 years old at that time with atrial fibrillation and cardiomyopathy. At that moment, we actually initially gave amiodarone and cardioverted him, and his atrial fibrillation, the ejection fraction got better to 40%, and we pursued towards ablation. At that moment, the concept of ablation in the setting of heart failure was not very strong. So after the ablation was done, he remained in sinus rhythm for a year with recurrence of atrial fibrillation, and he had a redo of atrial fibrillation performed, which resulted in being successful for another year. By that time, his ejection fraction completely recovered, but he remained in atrial fibrillation since 2012. Until 2020, he came to me now with heart failure with preserved ejection fraction. Very surprising. So why should that be a case in a patient who presented with a reduced ejection fraction changed to preserved ejection fraction but symptomatic atrial fibrillation? Now, when we took this patient, and I wasn't really convinced that I need to go for an ablation, the patient in fact insisted with the technology change, why can't we give it a try? He is now 83 years old, as you can see. As we are ablating in the posterior inferior location, because of all the high density mapping what we have, the rhythm actually started organizing. Now, we left with a biatrial flutter in this case, which involved the Bachman bundle area, and as we ablated through the ablation in this particular the flutter, it terminated, and this patient, we went from a persistent atrial fibrillation for longer period of time to termination. So this patient remained in normal sinus rhythm as of now in the last almost 5 years in January, and with the complete resolution of symptoms. So this gives you a perspective of concept of chronic atrial fibrillation, what it really means. We don't really understand the pathophysiology. We all have this idea that the patient has such a long persistent atrial fibrillation, you cannot really treat with rhythm management. So one of the aspects of non-pulmonary vein triggers has been elegantly described by Xian Chen's group, and the many other groups have actually showed. And this is a very important part. We hardly think about it because of all the trials that have been so far published talking about the other non-pulmonary vein triggers. So the interesting concept of Ben Sherlag years ago demonstrated in the vein of Marshall. You already heard about this concept, looking at the sympathetic parasympathetic nerve endings in the vein of Marshall area, and this becomes a trigger for atrial fibrillation as well. And the structure is complex, it can be quite difficult, and that's why all these epicardial talks we talked about, we listen to that. And these areas can be quite difficult to really access sometimes in the endocardial location. So this becomes an important source of atrial fibrillation as well. So this led to a very nice, elegant study from the Bordeaux group, which is called a Marshall Plan. What they essentially did was they targeted several areas. One area being the saddle area, right in between the left superior pulmonary vein and the left atrial appendage area. Then they addressed the vein of Marshall with an alcohol ablation, if feasible, and then the mitral isthmus region. If you do along with the roof line and the pulmonary veins in this set of patients with persistent atrial fibrillation, the outcomes were very good, long-term outcomes. So this led to the concept of understanding the non-pulmonary vein triggers. So let's look at the data from the Cabana trial, which was published, which was the per protocol analysis, looked at the death, disabling, stroke, and the serious bleeding or cardiac arrest. The ablation favored drug therapy. So that is one of the early trials of the atrial fibrillation randomized study. So we all know that atrial fibrillation, it can cause arrhythmia-induced cardiomyopathy. As in this case, you can see before the ablation and after ablation, there was a significant improvement in the ejection fraction after keeping the patient in normal sinus rhythm. The Castle-AF trial showed that in heart failure population, ablation is very beneficial. It is superior over the medical therapy. In the death or the hospitalization due to heart failure as well as heart failure hospitalization, both were better in the case in patients who underwent ablation. So this led to another major trial, which was in end-stage heart failure patients with atrial fibrillation. So the intention of this trial was to see if the ablation in this group of patients are safe and efficacious. It was a very nice trial to demonstrate the primary endpoint of death, implantation of left ventricular assist device or the heart transplant in this group of patients, they found that the primary endpoint were achieved with ablation being superior compared to medical therapy, 8 versus 30%. It was successful, and the patients were actually removed from the transplant or the end-stage heart failure therapies. Death from any cause was also superior with ablation compared to the patients who were treated on medical therapy. So this leads to a lot of things, concept of understanding that atrial fibrillation, we are actually thinking in terms of rhythm management as a primary modality of treatment. If you look at the heart failure trials across the board, 6 out of 8 trials which has been published so far, even in the persistent category, has been rhythm management. It supersedes the rate control. So this is a major shift in how we actually are treating patients with atrial fibrillation. So needless to say, the rate alone is not very important. We published this paper few years ago looking at RR dispersion. When you look at the RR dispersion in this group of patients, even if their rate is controlled, average rates is controlled, it significantly impacts the outcome. In patients with a significant RR dispersion, it behaves like arrhythmias like a tachycardia causing heart failure, as opposed to patients with less RR dispersion. So that is a very important piece of understanding, that rate control alone is not helpful. So there is another novel concept is called the ripple frequency mapping. This is currently under a randomized trial being done, and we were the part of our earlier pilot study demonstrating the non-pulmonary, non-antral location identification of this ripple frequency maps, and ablation improves significantly the outcome of these group of patients. So we all are aware of the high power short duration ablation procedure with the Q-dot was quite beneficial and useful as far as the outcomes are concerned. I didn't touch upon the cryoablation. We elegantly heard from Dr. Miyazaki earlier. Now, what is the major paradigm shift now with all the new modalities of treatment? That the major paradigm shift is the concept of what we know as the pulse field ablation. As you are all aware of the pulse field concept of creating electroporation of the bilipid cell membrane using the high voltage currents, many algorithms have been written to cause the cellular apoptosis. The main thing about this particular concept is it keeps the structure intact, despite the ablation lines are being created. And this has been controlled or modulated using various types of a pulse waveform, and hence you can actually monitor and titrate in a different ways. Now, needless to say, this is in the evolution process. As you can think, we have already passed more than 20 years in RF world, and the PFA is very early in the infancy when it comes to the outcomes at this point of time, because of the fact that we are still learning. So the biggest advantage of pulse field ablation, which is a major change that we have seen, is the collateral damage. So far we know the collateral damage in all the trials have shown to be very, very substantially low compared to what we learned from other sources of energy. So that's probably one of the biggest reasons this technology is growing very fast, if you look at among all the key opinion leaders who think about this particular modality of treatment. So we all aware, I think one of the aspects of pulse field ablation is the left atrial dwelling time is very short, ultra short, and achievement of ablation can be done fairly quickly. I mean, it has got limitations, no question. I think in the process of learning more about this one, there is over 200,000 patients already experienced across Europe and the United States, and with very least complications that we have so far seen with outcomes similar to RF. Obviously, the outcomes are still, we're working on that concept because of some limitations what we understand with this pulse field ablation. There are many systems have been currently developed. You heard from Dr. Su earlier about this concept, and are currently underway, and we are learning more and more with the different systems, and I think we will have a lot more interesting findings down the road what we know about these systems. Now, looking back, what we understood with the earlier slide, I talked about the three concepts of the ablation. Now comes, we change paroxysmal, persistent, all these things are in the background, but what we need to really understand is stages of atrial fibrillation. This is probably one of the most important thing what we need to know. That's probably one of the reasons why atrial fibrillation becomes a very difficult one if you don't understand. We have to actually start very early at risk for developing atrial fibrillation, address all the potential cardiovascular risk factors which can lead to atrial fibrillation. Then identification of the pre-atrial fibrillation concept in the form of even as simple of atrial ectopy to short bursts of tachycardia. These could be highlighted. Needless to say that if you intervene at this stage, maybe we can prevent the atrial fibrillation. Then when it comes to this, as you can see here, the arrow shows in both directions. The paroxysmal to successful ablation, it can go both ways. That means if you intervene and do all other modifiable risk factors, we may actually take care of this atrial fibrillation, and all the definitions of what we understand about long-standing persistent atrial fibrillation or the persistent atrial fibrillation will change. So it is an important aspect to understand. We already know, I think when you look at the substrate in some paroxysmal atrial fibrillation, we see extensive scarring, and some patients with persistent, not much scarring. So we really poorly understand what really happens when it comes to what the older definitions of atrial fibrillation meant really. So it is only the fact that when we cannot really successfully do an ablation with permanent atrial fibrillation, then we call it as a permanent when we don't have an answer to that treatment modality. So what we need to do with respect to pillars of atrial fibrillation management, we need to address all the risk factors, which actually becomes a foundation in treatment, and shared decision making with the patient, how we really approach this patient. Stroke risk is one of the important aspects we need to address. Then optimize the modifiable risk factors and the symptom management in the form of a rhythm control, which I told you about the upper hand as opposed to the rate control in the atrial fibrillation management according to the current guidelines. So the take home point with respect to paradigm shift is the change in the nomenclature of atrial fibrillation. Instead of talking about the paroxysmal, persistent, long-standing, we need to think in terms of stages of atrial fibrillation. That actually makes us, I think, identify and treat these patients appropriately. So AF risk factor modification is a very important aspect. No matter what we do with respect to tools that is available, the patients don't do very well if we don't take care of all of the problems. So the flexibility in using the clinical risk score and expanding the CHATS-2-VASC, and there is M-CHATS-2-VASC, Atria score, many scores are available to identify this, are a very important modalities of risk stratifying the patients for stroke prevention. And the consideration of stroke risk modifiers are also are shown in this particular guidelines. Early rhythm strategy is taking a very upper hand. Now, atrial fibrillation catheter ablation has taken a class 1 indication now in selected group of patients, as opposed to all along we were giving as a class 2A indication. Now, in heart failure, it takes an upper hand too, based on the Castle AF as well as the Castle HTX trial. And the recommendations have been updated in the device detected atrial fibrillation, which is a major paradigm shift based on the current guidelines. And the appendage occlusion devices in the management of stroke prevention became a class 2A in the current guidelines. So there is a major paradigm shift as well. So as we learn more and more on the combination procedures with ablation and occlusion devices, I think we may be doing a lot more earlier intervention in this group of patients. So recommendations are made for some of these patients which they're not so benign when it comes to some of the atrial fibrillation you see with acute medical illness or surgery, I think are the precipitants which may eventually need to be much more in close proximity followed. And with that, thank you so much for your attention. I know it's a talk before the lunch hour. It is always difficult to really focus, but I really appreciate all your presence. Thank you.